Is the haematoma block something you use for reducing distal radial fractures? Hello and welcome to this week's Urgent Bite, brought to you by the Royal New Zealand College of Urgent Care. My name is Guy Melrose and today we're asking the community a question. Do you use the haematoma block to reduce a distal radial fracture? Distal forearm injuries, usually from a fall on an outstretched hand, are a common presentation to an urgent care clinic, and whilst subtle bony injury can sometimes be tricky to identify on initial x-rays, a displaced distal radial fracture is obvious, both clinically and radiologically. The classic Colles fracture is angulated and usually shortened and often comminuted, and needs to be reduced back to an anatomical normal by a combination of traction and manipulation. When the displacement of the fracture position is minimal, it may be that conservative management without reduction is advised. This can depend on age and comorbidities and is usually best discussed with an orthopaedic surgeon. But once the decision to reduce a distal radial fracture is made, the patient needs adequate anaesthesia to enable the procedure to be performed. Options available include the ischemic arm block, also called the Beers block, which involves intravenous local anaesthetic in the affected arm, whilst a double-cuffed tourniquet prevents systemic spread beyond the arm. Procedural sedation, which can include drugs such as ketamine, and a haematoma block, which involves injecting local anaesthetic directly into the fracture. Once the patient is suitably managed from an anaesthetic point of view, the reduction of the fracture follows the same pattern: reduction, casting, check x-ray, and orthopaedic follow-up. And regardless of the technique used for anaesthesia, failure to adequately reduce the fracture may mean the patient proceeds to a full general anaesthetic and an open reduction and fixation. Now, here in New Zealand, Beers blocks are the domain of the emergency department, or at least they are in Auckland, Hamilton and Tauranga. It requires having the double-cuffed tourniquet to provide adequate pressure above the patient's systolic so as to prevent the IV local anaesthetics seeping into the rest of the body with resultant systemic toxicity. It requires at least 2 staff members present, and there is a period of post-procedure monitoring required until the cuffs get deflated. Because of the equipment needed and the experience required, it has therefore not been a technique used in New Zealand's community urgent cares, and emergency departments and orthopaedic teams are accepting of this, and patients are referred up to them for this procedure. If you do perform Beers blocks in your community urgent care, please let us know your experiences and your local policies. Now, likewise, procedural sedation is not performed in community urgent care clinics in New Zealand. It is performed in ED with suitably trained airway specialists on hand and is only done out of hospital by intensive care paramedics and helicopter emergency specialists. So that leaves us with the haematoma block, an infiltration of local anaesthetic directly into the fracture haematoma that is done whilst under aseptic technique and really just requires a needle, syringe and the local anaesthetic. If you have point-of-care ultrasound, you can use this to aid the injection, but it is usually done simply with palpating the fracture, and the location of the needle can be confirmed with a flashback of blood. Now, one reason that the Beers has become the go-to regional block for distal radial fractures may be due to the Cochrane review in 2002 that found, with insufficient robust evidence, that the haematoma block provides poorer analgesia. Yet a more recent open access paper from the Journal of Orthopaedic Surgery and Research in 2018 by Tseng et al. Compared haematoma block with procedural sedation and found it a safe and effective technique without inferior pain relief. The paper is linked in the show notes. Another reason that the haematoma block is not favoured is the thought that injecting the fracture site might create infection within the fracture. Now, I've not been able to find any evidence to suggest there is increased risk in my searches so far, so I'd be interested in hearing from the community as to your thoughts and experiences on this. Now, as I see it, there are a few advantages to performing the haematoma block in our patients. Firstly, in New Zealand, it will prevent patients being referred to the hospital, extending their medical journey on the day and increasing the number of clinicians involved in their care, therefore increasing costs to the healthcare system, and also tying up ED staff who would be using the time to attend to sicker patients. When you weigh up the beers versus a haematoma block, a single injection might be preferable to an intravenous injection and high-pressure cuff, that cuff being all that stands between you and lignocaine toxicity. If I were ever to require this in my own arm, I would probably choose the haematoma block if I had the option. And the haematoma block is not dissimilar to other nerve blocks and local infiltration that we do every day in urgent care, so it does not require us to maintain the skills and the equipment that is needed with the beers. It also does not require the same length of time to be observed afterwards. So my question to the community today is, do you use the haematoma block in your urgent care? If you do, what have been your experiences? If you don't, is it something you would consider? And if you don't, is it local policy that is stopping you? Or is it orthopaedic resistance to this technique, for example? Let us know your thoughts via podcast@rnzcuc.org.nz, and we will discuss this further in a future podcast. We'll be back next week with another podcast. I look forward to seeing you all then, but for now, thanks for listening.